I'm just going to give it a minute for participants to join in, and then we'll get started.
That'll give me a minute to shut down my phone so it doesn't talk to me. There we go. No pages or anything.
All right, I guess we'll go ahead and get started. Thank you for joining us today for our 5th Montana Fast Chat, which is our series of stroke education webinars. You can find the first 4 if you Google Mission Lifeline Stroke Montana and click on provider education. So briefly, just before we get started, Mission Lifeline Stroke Montana is an American Heart Association initiative funded by the Helmsley Charitable Trust to help enhance Montana's stroke system of care so that where you live doesn't have to determine whether you live, or a lot of times in the case of stroke, whether you live with disability or can even return back to your home. And so if you're not yet participating and interested in joining our project, you can please feel free to contact me at joni.guzman@heart.org, and I'll pop that in the chat here when we're done. And just a couple housekeeping items. We'll go ahead and get this webinar going. And if you have questions along the way, you can feel free to type those in the chat. And at the end, you can raise your hand if you'd like to come off mute and ask those questions as well. And so with that, I'm going to turn this over to Penny Clifton and deAmbra Coleman to talk about nurse-driven protocols in the setting of acute stroke. So thanks, ladies.
Hi, everybody. This is Penny in Billings, and I will speak for both of us and just let you know that both of our hospitals did, as many of you did, receive the grants from Mission Lifeline to help to support activities such as this. That's really our only disclaimer. Who's progressing the slides? There you go. Okay. All right. For this nurse-driven protocol presentation, we're hoping that by the end of our time together, you can grasp the value of nurse-driven protocols in time-sensitive nursing care, such as acute stroke care. Begin to take a look at your own system and processes to figure out which pieces of care can be linked to protocols like this, how to identify them, work through them, build them, align them to national guidelines, and then if you're on an electronic medical record, some ideas for how to take what you build and make it work with whatever was built into your electronic medical record. So this really is not a new concept, and you are likely already there. Oh, I'm sorry, I'm the wrong slide. There's lots of different definitions for protocols, but for the most part, and for all intents and purposes, these describe cascades of events that happen after an agreed upon trigger, a set of things that people know to do that's evidence-based and driven by national standard and best practice care based on an established trigger. Protocols are not and should not ever be about relieving anybody of work. So it's not about a protocol getting nurses to do stuff so a provider doesn't have to write orders. That's not what it's about. Now, for time-sensitive care like stroke, trauma, and MI, the protocols we're going to describe and the actions are taken by registered nurses in well-defined emergency care situations, and it helps to speed up the diagnosis and treatment of a patient or maximize their safety in an emergency setting. This is not a new concept for any of you. You are likely already utilizing a lot of nurse-driven protocols. For example, patients who are medically sedated and paralyzed in the ICU get what are called sedation vacations in the morning, where the medications are weaned off so the patient can awaken and be assessed, and then usually they are remedicated, oftentimes at a lower dose, and all of that is driven by protocol to help reduce the risk of ICU-related delirium. IV sites that are started in the field are usually recited very early in the admission and again every 72 hours to reduce the risk of site-related line infections. There's a series of nursing administered dysphagia screens. Now, these are not diagnostic in the way a dysphagia assessment by a speech language pathologist is. That's not what that's about, but these are screens with enough sensitivity and specificity to prevent aspiration early in stroke care. And then finally, everybody probably has instituted the bedside mobility assessment tools that are administered on admission to patients and repeated as needed to make sure that the healthcare team plans for a patient's unique mobilization strategies, their strengths, weaknesses, and adjunct needs. So this is really just a short list of practices that are based in evidence. They are beneficial or risk-reducing for patients, and they can be initiated by nursing for patients who fall into specific categories. That's what a protocol is all about.
So in her article on nurse-driven protocols, Lisa Lockhart made specific mention of the concept of a stroke team or stroke alert or stroke activation processes as protocols, and highlights that these only work if there is a clear education about the path into and the steps of use of any protocol. So if you consider that it takes time for the nurse to call or page a provider, time for that person to call back, time for the SBAR report to be given, time to write or enter an order, then you can envision the benefit to beneficial, timely, and autonomous nursing care when all those time-consuming steps are eliminated. So protocols within emergency stroke care hit all three of the goals of any given protocol. They reduce the risk of inherent delays. Because of risk reduction and because of time as brain, they can improve outcomes. And for the most part, the things you can do are already known to have value. For example, it's clearly recognized that the lysis of clot in ischemic stroke reduces infarction, ischemia, and therefore disability. Well, since one cannot proceed with giving a lytic without a CT scan, any protocol that expedites the CT will by default expedite the lytic and then reduce the disability. So let's do the example of TPA and TNK, which are the lytics for ischemic stroke. And stroke centers of excellence will keep track of the dorsal needle time for these events. In other words, we're looking at from how long when they arrive to your door to the administration of the lytic. So in centers that only give this medication occasionally, each event can be analyzed for opportunities. So we'll look at how fast was the stroke recognized, when did the provider arrive, when was the CT ordered? When was it read? When was the TPA or the TNK ordered? And then when was it given? And the work towards building a protocol, all these points of care are analyzed for opportunity. Larger centers in Montana do the same thing, but with perhaps 30 or more of cases, of TPA, we may be more likely to look at trends as well as within individual events for opportunities. The use of lytics and how the CT and labs contribute to the decision are defined by the American Heart and Stroke Associations. So drivers for protocols can be found in the national and regulator standards. Using a tool like Get With The Guidelines can, over time, allow a hospital to compare itself to regional or national benchmarks. Penny?
Years and years ago, in an ICU that I worked in, a patient came out of the operating room and the anesthesiologist said that he had been having trouble getting a good blood pressure. That alone is alarming. So he was just giving the patient little boluses of neosynephrine IV. Yeah. Now, the nurse that I got report from told me about it. And then she says to me, so from now on, we're going to tape an ampule of neo to the IV pole for every case. She made a protocol based on a desire to please that doctor when there were real and much bigger questions that should have been asked, like why couldn't he get a blood pressure and what was the matter with the cuff? So protocols should not be made in a reactive fashion. They need to be made in a responsive fashion. So consider that single event and how you might have analyzed that when we talk about the FISHBONE process. So once you've identified either a national standard or regulatory guideline that you're falling short of, or there's been an event with a care delay or an unexpected outcome, whatever the driver is, it helps to use a methodology to tease apart all of the pieces that are either contributed to the event in a negative way or are ways that will contribute to a more positive outcome. So we got our 18th clot retrieval patient today. I just told the girls before we started talking. We paged the clot out at 6:30 this morning. And then when the patient arrived in the cath lab, because we paged it out before she even arrived on the property, when we paged it out, when the patient arrived in the cath lab was like 7:30 in the morning. So it straddled a change in shift for anesthesia. And anesthesia has to attend every one of these events. So now what we're going to look at from a FISHBONE standpoint for this event is the guy that was going off call didn't think he needed to be there, and the guy that was coming on call didn't think he needed to be there. So we had a brief delay when nobody was there, and now we need to FISHBONE it and see what the problem was when somebody straddles a shift change. So you can use a FISHBONE process to tear apart a piece like that. So let's take, for example, the use of a stroke team. Now, under equipment, you're asking, how is the paging taking place? Are we using pagers? Are we using cell phones? Are we using an overhead process? What are the technical glitches like dead zones or time delays from sending the page out to receiving it? Years ago, we all had those little brown pagers that clicked on our belts, and they would build these ginormous pages that had time last known well in it, and gender and past medical history and all this kind of stuff in it. And we found that the bigger the page was, the longer it took for it to get to the tower and for it to get sent out. So within that equipment tab, we figured out a couple of things that were sort of delaying the paging process. Under process, this will be all about who does what towards the outcome of the team, the step-by-step process, who labels it, who calls the person who pages it out, all that sort of stuff. What kind of people responded it is under the people. Who's on the team? Why are they on the team? Do they need to actually show up, or do they just need to be made aware and be waiting until they get looped into the actual process? If the stroke activation is a triggered event, under materials, do we need posters at the desk? Do we need badge cards for the nurses? Do we need posters in the MS crew so that everybody is working off of the same triggers? What materials and deliverables can we build that will support the process? We found that environmental noise and the level of work and agitation in the emergency department easily affects what is said and what is heard, and how things like requests for stroke activation can be lost. So part of environment has to do with, for example, the repeat back process that we do with all verbal orders, so that people verify that they're, what the direction they gave was actually heard. And finally, under management, from an administrative standpoint, showing the value that leadership has for this process by investing real dollars in it and budgeting people the time to build these things and the materials they need to roll them out and then monitor them. When administration shows value in building one of these protocol type processes, then the people who work within the protocol grasp in a better way that it really does have value, because an investment's kind of been made in them. Former South Dakota Senator George McGovern was quoted as saying, "The longer the job title, the less important the job." And in small facilities all around Montana, we all know that one can easily accumulate a lot of responsibility, wear a lot of different hats without any real increase in hours to put into the task. Hospital administrators in the management piece of the FISHBONE here, who demonstrate real and visible value for these stroke program coordinators, especially in small hospital committees, they communicate to the staff in general that this work really matters. So there is a role for management in any one of these FISHBONEs. So the FISHBONE then produces things that need attention, and these things can kind of fall into each of those 6 categories on the FISHBONE, and then we can further drill them out into what's called a SWOT gap analysis. So these are things that are strengths in your program, weakness in your program, opportunities for improvement in your program, or things that might be actual threats. And this is a real good partner for a FISHBONE because it allows you to sort of analyze and put things and figure out what you're going to work on first. Remember that change of any kind is usually perceived as a threat to those who are either just afraid of change in general, or they're afraid of maybe having to work harder, or maybe they're afraid of having to work more transparently. Those people and their negativity probably are the biggest threat to any process, as can maybe a stakeholder in the process who's both kind of passively and passive aggressively not really supportive. I recall we had an ED provider here who was so annoyed at the autonomy of the nurses in calling stroke activations that, and we, not only the nurses were calling them, but they were expediting the patient to CAT scan quickly, that he had a patient removed from the table in CAT scan, returned to the ED, and stood in the room while she was disrobed so that he could conduct his pointlessly detailed assessment. This ended up being a TPA patient, and he delayed her time to lytic so profoundly that it generated a giant peer review. But somebody like that, those people are informal leaders and power bases in an emergency department, and they are and really should be categorized as threats in a SWOT analysis. So program medical directors and administrators who allow behavior like this to go unchecked, you're really kind of communicating to the staff that the protocol is not worth their risk in dealing with such an individual. So it's important to be really honest about what the threats are to the development of the protocol as you head into it. deAmbra.
I advanced, it just slightly changed, sorry.
Oh, okay. But
Here we go.
seems to be taking its time advancing.
Okay, so
Why did that freeze? That's done that before. Oh, click it again, because what
So
it
there
did was
should-
just, yeah, it just threw the fishbone in. Now click it one more time. It should go to the next slide. There we go.
Okay.
Okay, good.
So keep the project as clean and simple as is possible. So step one will always be the identification of your stakeholders. The core of the work of W. Edwards Deming in the revitalization of the Japanese economy after World War II was that he valued the voice of the worker on the front line in the early automotive industries. Deming was one of the first to talk about the systems theory, that any organization is composed of a system of interrelated processes and people. This is the value of finding all the stakeholders. They contribute to a full understanding of both the upstream causes and the downstream effects of a protocol and the problem it is addressing. You need stakeholders to speak to all the different nuances. Recently in Eastern Montana, a patient presented to a facility with an acute stroke sign. That facility did not have a CT scan. The providers talked over a consult line and chose to fly out to get the patient and bring them to the regional stroke center. Had they had other voices in the discussion, they would have learned that the patient was a 20-minute ambulance ride from a facility that had a CT and also alteplase TPA. We could have flown to get them there and achieve the goals of imaging and treatment in a timely fashion. But the providers having the discussions weren't thinking with systems. Look for stakeholders in each limb of the fishbone in every point along the continuum of care. The fishbone diagram breaks the problem or goals down into different areas of interest and work. It also, in its own way, resembles the scaffolding of a new construction.
Go ahead and, deAmbra, go ahead and click it so that scaffolding picture comes up. So that's illustrative.
Yeah.
I shouldn't put animations in here without warning you.
Oh, here we are. Thank you.
Yeah, okay.
Okay, here we go. A scaffolding gives workers safe paths and access to do the work and a solid framework on which to hang their work. A scaffold supports the process build until it is firm and can stand on its own. Protocols take time and people and work, and they aren't as simple as taping an ampule to an IV pole. Oh my God.
Yeah,
so the scaffold for any protocols will include the people who will utilize it all across the continuum of a patient's hospital course, the clinical guidelines that support its development, the tools necessary to use it, the tools and people necessary to analyze it when used, the money needed to pay for the build and the rollout and daily use, and the plan for how to onboard new employees. So as you can see, it takes everyone across the continuum of care to be able to provide input for these processes. Penny?
So now, let's take a look at some possible nurse-driven protocols then in stroke. So let's start with the core component of stroke care, which is stroke recognition. Recognition begins in the home, at the scene, in the EMS rig, at the triage desk, in the ED. We had to rebuild our stroke activation team processes about 12 years ago here at St. V's. We were changing neurologists, we were changing coordinators, and it was really pretty much time just to dust things off. We also had a brand new pager system coming as well as a new EMR. Now, our ultimate goal was that the nurses taking radio call, assessing patients at the triage desk, or assessing patients at EMS arrival would recognize acute stroke team criteria that fell within the TPA treatment window, and they would launch a comprehensive team process. The equipment of interest was going to be the paging system, how to build the pager groups within the new system, what the page would look like on the system, and how it would track the receipt and response of the pages so we could make sure the right people were getting it and were acknowledging it. The process required that we look at the criteria for activation. We knew from the success of trauma programs statewide, these criteria needed to match what was used by EMS and also what was used by our partner facility down the street at Billings Clinic. It had to match. If it didn't match, the inconsistency would result in a lack of development of EMS's ability to recognize stroke. Both hospitals in Billings can provide TPA. In fact, any facility with a CT should have TPA on the formulary. So we used the time window for TPA as one component of the activation. The other was the existence of a focal neurologic deficit. And you can already begin to see here the depth of the education and training that was going to be needed once we built the scaffolding to make everybody within the scaffolding be able to work in the same way. Every ED nurse and provider needed to be educated. EMS in both our local and regional transfer regions began getting stroke content at annual conferences. I began doing and had been doing annual refreshers for years. We also built ways for someone to audit the accuracy of the activation calls and the responsiveness of the team. When you build a protocol, making sure that people follow it, especially if they don't follow it, if they're not following it because it's bad, then you can figure out how to fix it. So you have to determine that people are actually doing it. And there were plenty of other departments with skin in the game who went in on the activation pager groups: pharmacy to mix the drug, house supervisor to bed the patient, stroke team nurse from the stroke unit to aid with the assessment, the neurologist, the CAT scan tech to prioritize the bed, lab, because we put all the stroke labs in a red plastic bag and sent them in the pneumatic tube system, so they're watching for the red bag, ICU supervisor to see if they were going to have a bed in case it turned out to be a TPA patient. So there was all these people that needed to be involved, all sorts of people that needed to be trained, all of their voices that need to be present at the table about the downstream impacts of activation. All of that stuff needed to be built. That's where this fishbone diagram comes in so importantly. We built the criteria at the same time that we were building the team. Now, there was a pad of report sheets at the EMS radiophone in the emergency department, and we worked with the forms committee to rebuild it so that it would have visual reminders of the activation criteria. This is something that would fall under the materials tab in a fishbone, of something that will help make the process more successful. When FAST changed to BFAST, we went back through the same process and added balance and eyesight to the algorithm. We amended the form. We also built a huge number of smart phrases, which are like automatic nurses' notes to accompany this process, because by using the smart phrases, it drives consistency in the care and documentation for nursing. It not only educates, but it drives excellence in the process. And I know this seems really far afield from the actual activation process itself, but remember, it reflects that we have a systems awareness of all the moving parts that are going to make this event successful. Again, let me reinforce that all of this work creates value within a protocol. So this is the scaffolding for it. So this is a smart phrase nursing note that was built for the stroke nurses, and it documents a lot of time-sensitive pieces in here. We get the time last known well. We use a rapid product for analyzing CAT scans. We get the rapid number in there so we can always find the patient's scans in the database. We have physician response times in there. When we added thrombectomy, we had to begin to be able to do modified Rankin scores with these activated patients to determine if they were candidates for thrombectomy. We put our large vessel screening score in there. So we took the activation event and we built products like this to give it more value and give it more depth. These are all protocolized pieces. Everything in this note is protocolized. It does not require any order. And if you look in this, I hope what you can see is the quality of the autonomy within nursing here to gather all of this data, to do modified Rankins and bands and NIHs and communicate with the providers over the phone. There's all sorts of data points in here with quality and things that can be measured.
So originally the trauma team processes had this paper order set. It is well known that verbal orders are supposed to be left 4 times when writing is not possible or it delays your care. That's truly the definition of stroke and trauma activations, isn't it? So we took stroke, we added it to this paper order set at St. Vincent's. We built a policy that supports the RN launching this order set as soon as the activation is called. No providers required to sign this, but if you look down the list of orders here, you can see that everything needed to get towards diagnosis and treatment is here. This actually matches what is in the electronic chart. And what happens is that the RN signs it, gives it to the ward clerk, who puts all the orders in, sometimes even before the patient arrives. So what used to happen for us was arrival, bill the account, provider sees the patient, trots back to his computer, enters the orders. Do you hear that clock ticking? Remember, time is brain. So also notice that we can update this when care changes. So now that we are doing thrombectomy, we added related imaging. So this is the stroke alert orders built by the Montana Stroke Work Group. While we did not write it to be used by nurses, it is entirely possible that any Montana hospital can draft a stroke activation policy that empowers an RN to launch these orders. Think about the value after hours when the provider may not be in-house. Protocolize both the ability to activate the team and ways for nursing to get started on all the care and diagnostic work that happens with every activation. Note that on this order set, we have X'd some of the boxes as defaults because they happen every time. Also notice that things are numbered in the order of occurrence that best suits stroke. You want to rule out your low blood glucose, get them assessed, oxygenated, lines, and imaged. Note that your 12 lead happens after your CT. It should never delay that CT. In this way, orders such as this can even organize care in a more clinically expert order. Can you see how empowering this is for nursing? Nurses are educated to be autonomous healthcare providers with their own practice and a shared clinical knowledge base. Protocols like this establish roles for members of the team, gives them focus and purpose and engagement. They're no longer just following orders, they are launching a protocol. When building protocols for stroke care, it is important to do the research to identify the best components and processes. So just like we align our stroke team activation and diagnostics processes with national guidelines and strategies, when it becomes time to empower nurses to screen for dysphagia, we need to do the work to pick the tool that demonstrated good sensitivity and specificity for stroke, is safe to be administered by nurses, and supported by good size studies that included a lot of stroke patients. This is the short list of dysphagia screens that are out there that each have their fans. As you can see, there are many. The Montana Stroke Work Group has also built a dysphagia screen tool based on high quality studies for use by Montana nurses. In order to protocolize things like this, that is where it is so important to do the work to look at the size and outcomes of the studies that produce these swallow screens. So we know we are empowering nurses to use something autonomously, and that is good. Penny?
You can see where all of this fits into a continuum of care. To protocolize the activations and accompany it with a protocol order set resulted for us in more pre-arrival and timely activations, more accurate activations. The providers had tended, to be perfectly honest with you, to want to lay eyes on patients and before they would pull the trigger for activation. And this created a lot of delay and layered in an awful lot of subjectivity when it came to how they interpreted neurologic findings. The stroke team lived up to the promise of being at the bedside within 15 minutes. We made that commitment with the activation process that we would be there to support, and that relieved an awful lot of anxiety. And for us, our stroke team is the stroke nurse from the stroke floor and the neurologist, either physically present during Monday through Friday or 7 days a week during daylight hours or remotely after hours. Once the CT order was already in, CT was better prepared so that we began being able to take the patient from EMS directly to CAT scan because the tech knew the patient was coming ahead of time, and that really dumped our door to CT times. So now let's talk about the last piece for us, the last extension of the stroke activation process, giving the nurses the autonomy to call the activation themselves. If we started with our ultimate goal of getting patients to alteplase more quickly if they were candidates, part of that was protocolizing activation, part of that was order sets. Now let's take a look at this last piece, which was protocolizing the preparation of TPA. So when I picked up the stroke program back in 2010, we had a lot of fear regarding alteplase, especially on the part of ED providers. For a very long time, their professional organization, ACEP, had been really skeptical of the NIH TPA research and what the actual risk-benefit ratio was that was associated with TPA and stroke. So we basically had to ask them to step back and commit to our stroke team processes and commit to being there to take the decision-making weight off of them. And about determining whether or not, the patient was a candidate for TPA. When we layered this in with our activation protocols and became more rapidly responsive to their need for help, we showed value for them and they gave us value in return. We focused back then on activation and door to needle times, but eventually we had optimized activation, we had optimized the door to CT times, and still our door to needle times were kind of stagnant. We hadn't quite moved the needle as much as we wanted to, no pun intended. The drug was being mixed in the pharmacy by pharmacists, and any of you that are familiar with TPA know that that's not necessary, that it can be mixed and should be mixed by RNs, and that does not require to be mixed under a hood. But I got to tell you, it was really hard for us to get pharmacy to release that drug from under their control. It was just a very hard sell, but it kind of illustrates the work that went into getting this switched and changing the protocol from where it was being mixed. So I collected data aggressively for about 18 months. Arrival to CT, CT read to TPA order to administration. I mean, there were all these different touch points that had to be analyzed before I could point out that the patients were getting activated, they were getting seen, they were getting imaged, and the drug was getting ordered. But at the point of the order, the clock slowed down. And that was because the pharmacist was trotting upstairs the steps to the pharmacy, mixing the drug, and then trotting it back downstairs because you can't put it in the pneumatic tube system because it shakes it up and puts bubbles in it. And all of that was costing the patient time. So we went back to kind of owning it, just like we had with the Alteplase decision. And now the stroke team nurses who come to the ED from the stroke unit all know how to mix the drug. They've learned how to mix it and how to prime the pump to give it. These stroke boxes that we built would fall on the materials tab for a fishbone analysis. There are 3 of these boxes. The stroke nurse has one personally, there's one in the ED, and there's one up in the pharmacy that the pharmacist will bring to every activation. If they bring it to an inpatient bedside, then that's the one that gets used. If they bring it to the emergency department, usually we trade out and the used box goes back to the pharmacy for restocking. So we'll use either the ED one or the stroke nurse's box. They contain these boxes, and that little stroke box is only about maybe 6 inches side to side, 10 inches tall. It's very small, but it has everything necessary in it to mix the drug. It has the drug, it has calculators, it has labels, it has directions on how to set the pump, everything, it has the tubing, everything is in there. One of the things I'll mention is that this process, usually we have to barcode the patient and barcode the drug to align them in the electronic medical record. Hate to tell you this, that costs the patient time too. So we are handwriting the label. We built a smart phrase to support the nurses in this process. And as soon as the label arrives from the EMR, we'll slap it on there. But by handwriting the label, we found it really cut into a lot of time. Verbal order for the drug, mix it at the bedside, slap a handwritten label on it, and then replace it with the barcoded one. And it has worked, really has worked just fine. Next slide. Sorry.
It's okay.
To support the nurses and to create a culture of safety, we built additional smart grade products into the EMR so they could find everything they needed in one place. The Alteplase exclusion list is in there. There's a place to do the calculation and have your calculation document that it was double checked by somebody else. We actually also built a series of consents in there so that there's no need to go running around looking for paper and a pen to try to get the patient to sign or get somebody to sign it. All of these pieces drive quality, they drive consistency, they remove variability, they increase safety, and they make the process go faster. And they're all designed to support the stroke box process, which is designed to support the whole door to needle thing after we had solved activation and solved CAT scan.
So the Montana Stroke Work Group has just finished the revision and update of a bank of order sets that can be used to envision protocols at your hospital. We have reviewed all the national guidelines to align these with best practice while keeping in consideration that many of these patients will not stay at your facility. There are many electronic medical record products. Even within one company, such as Epic, there are multiple versions. Often these products come with built-in order sets. Don't assume they are evidence-based or well-suited to your facility size and your workflow. So we would encourage you to investigate what your EMR has for stroke and compare the content with our paper order sets, which we are confident are best practice. You may be able to take that set and modify it to meet guidelines and save it as favorite for all. Be sure there is a process to assure that any locum providers will follow your plan and not theirs. This is your program. If you find that what is in your EMR is lacking, then the management limb of the FISHBONE is where you find that hospital administration permits the use of paper order sets and even paper nursing charting in order to promote best stroke care.
We've often talked about, use the terminology or the symbol of a chain of survival, and more in the education I've been doing with Mission Lifeline, I'm not using that chain any longer. I'm using relay races, because this is a speed related process and patients move across a continuum from home through EMS to ED, maybe to admission, maybe to flight out. Those patients count on us to build protocolized communication and care processes that help reduce time and maintain accuracy. There should be no fumbling at the handoff of the baton, which is the patient. And we should be able to use processes that get the next step already moving, so it's ready to move the patient faster towards the goal. And protocols are a really good way to meet that need. Acute stroke outcomes are really dependent on the accuracy of recognition and the speed of our response. Our speed, the actions that we take and take quickly in response, can be protocolized to create forward momentum for that patient towards the resolution of their ischemia and infarction. There is no nurse-driven protocol that will work into a vacuum. Nobody should be taping glass ampules to an IV pole ever. That's not a protocol. You can't build things in isolation. You can't build reactive processes based on one patient case. Fishbones are a great way to look at all of the moving parts of any process and make sure you have all the right stakeholders there to talk about their role, downstream and upstream effects, and get them all engaged before anything will actually work. The team picks the gaps, the goals, and the action plan. We've used a bunch of different images in this presentation. We wanted to make sure that we gave credit for that. And the Montana stroke order sets, if they are not already, I think very shortly are going to end up on Jason Gleason's www.montanastroke.org website for everybody to take a look at and use to inform their stroke care in Montana. And we're done, Joni.
Oh, that was fantastic. Thanks, ladies. Yes, the order sets, we're just waiting. We wanted them to be approved by the stroke medical directors at each of our primary stroke centers. So we're just waiting on one more sign off, and then we will have them available on our montanastroke.org website. And then we're also planning education around the order sets. And our hope is to visit each critical access hospital to talk about those order sets and stroke care. And so with that, I'd like to open it up to any questions anyone might have. I know there was one question as to whether we can share these slides. So Penny and
Oh,
deAmbra,
of course. Yeah,
okay.
of course.
Great. I'll send them out to everyone who registered to sign up.
Yeah.
I will be, this will be available for rewatching or sharing. We'll put it on the montanastroke.org website. It's just that I know Jason's very busy, so sometimes it gets to our Mission Lifeline Stroke Montana website first. I just have to have it closed captioned, and then we put it on a YouTube link, and then we can share that out. So yeah, let me check to see if we've got questions. Okay.
We'll give everybody back 21 minutes for their day. Hi,
Yeah.
Michelle. Thank you.
Yeah, great job, ladies. Thank you so much.
All right, everybody have a great day, and you know how to get a hold of us through Joni, gosh knows.
Thanks all.
Thanks. Bye-bye.
Bye.